Regardless of why we were called out to any particular rescue, by the time we actually show up, the main chief complaint of a lot of our subjects is going to be hypothermia, right? That's at least one of the problems, if not their main problem, by the time we show up, right? So regardless of what the situation is, what the time of year, but especially the time of year that we're going into, right, with the winter months. Okay, so mechanism of heat loss, this was, I guess, tested on that pre-assessment, and everybody did a pretty decent job of that, so we don't really need to dwell on it. Any questions about these 4 ways of losing heat? Right, so direct conduction, that's why we use insulated pads, right, in our hypo wrap tonight or when we're out in the backcountry. Evaporation, right, so we have to expend energy to convert that liquid sweat to a gas, right, and our skin, it has to stay hydrated to function as a barrier, and so in cold weather, when the air is drier, right, we're going to be perspiring more whether we realize it or not. Vasoconstriction, right, so this is that shunting of blood towards the core, trying to preserve like the main organs. But most important is metabolism, right? So this, I think, of all the questions we asked in the pre-assessment, this is the one that gave people the most problem. But it is by far and away the best way to make heat. And this will be part and parcel of our treatment. Risk factors for cold injuries, right? So this would come into play when we know what sort of patient we're dealing with, and we can think, well, they might be more at risk for certain hypothermic injuries than others, right? So young age, of course, old age, another one, right? Alcohol or other substances that impair your ability to make decisions, right? Like marijuana, things of that nature. Alcohol impairs shivering, that's the main reason it's problematic. Immobility, right? Somebody with a broken leg, not moving around, not able to exercise and generate heat. Being wet, 240 times faster when you're wet as opposed to when you're dry in terms of heat loss. So be careful crossing those snow bridges. And then if you're thin, right, for obvious reasons, right? Insulation, fat, not so much if you don't have it. Core temperature is going to determine if the subject is hypothermic or not, and it's important to remember that core temperature and skin temperature are usually 2 very different things, especially when we're in a cold environment. So,
what do you recommend is the best way to actually take someone's temperature when they are hypothermic in the field?
Well, my recommendation, which we'll get to on the next slide, is going to be we don't need to take their temperature in the field. Okay, so but notice, right, you have to drop your core temperature almost 4 degrees before you become clinically hypothermic, right? So when you're out there shivering on a climb or a ski, you're not actually that close to being hypothermic yet. It takes more than that to get to the point where we're going to become concerned.
I will say that the Wellness Medical Society's guidelines that were put out recently also are consistent with making a clinical sort of assessment, looking at the person, what all these sort of signs and symptoms we're going to talk about. Basically say that the forehead thermometers are no good. Anyone who's worked in the medical field sort of knows that. But and if you have a tympanic thermometer, that's like a little bit better. But really, for core temperature, it's rectal temperature, esophageal probe, which obviously you're not going to have, or bladder temperature, which also you're not going to have. So pretty much not much that we're carrying is really going to be very helpful. Fortunately, people progress down a pretty nice cascade of symptoms once they become hypothermic. So.
Exactly. So that's the whole takeaway for this portion of the talk, right? So these signs and symptoms are going to be an adequate surrogate for measuring core temperature, and regardless of the subject, that subject will exhibit the same stepwise signs and symptoms as their core temperature decreases, right? So the takeaway point is, as long as we're observing the signs that a particular subject has, that is going to be good enough for us to make the correct decisions when it comes to treatment. Here is kind of the recommendations or the data from the Alaska Cold Guidelines, and that really is the definitive source for a lot of hypothermia studies. So they divided hypothermia into these 4 stages, and we're going to reserve and hold off for that 4th stage, and note that's the no vital signs until the end of the talk, when Anna's going to talk a little bit about CPR considerations for severely hypothermic patients. So for us right now, we're just going to focus on these 3, right? So they're divided in mild, moderate, and severe. And these are the signs and symptoms that we need to key in upon. So for mild, the person is still going to be conscious, shivering. For moderate, they're going to have an altered mentation, and then for severe, they're going to be unconscious. So I would encourage you, just think about mentation, at least on like a first level assessment when we're thinking about hypothermia. Okay? In fact, our treatment is just going to be divided in between mild and then moderate and severe. And so what's the takeaway in terms of level of consciousness or altered mental status between those two main categories? Exactly. So the people in the top category, right, they're not going to have any change in mentation. They're going to be conscious. They're going to be fully functioning at their mental capacity, right? People in the bottom category are going to be altered in some way.
I will say that sometimes, if you're dealing with trauma, for example, or a head injury, you won't necessarily know if are they acting weird because they're cold or whatever, but basically just assume, like we were saying, that unless it's like you're in the desert in the middle of summer, in which case you should probably worry about heat stroke, not the opposite, right? That anybody who is a trauma patient, is a medical patient, anybody who's been out there for a while has hypothermia, and assume sort of worse as opposed to, oh, it's probably only mild because they've only been out here so long, if there's complicating factors.
All these treatments that we're doing, even for the moderate and severe, are not invasive treatments that carry a lot of side effects or risks. So when in doubt, feel you should be comfortable doing those additional treatments, right? We're not going to cause additional harm. So the takeaway here is when we're thinking about, is this mild, is it moderate, is it severe hypothermia, we're looking at their mental status. So a quick review about how exactly we do that. Right, we talked about the patient assessment triangle for those of us who came to previous trainings, like how we assess somebody in the backcountry context. And it comes down to just asking these 4 questions, right? So for person, what is your name, place, where you at right now, what is the general time of day or what day of the week is it, and the event. What brought you out into the backcountry today? What were you doing before we showed up, right? Things like that. And it's simply, if they're conscious, they have no problem answering these questions, assuming baseline, they don't have any deficits, right? But if they have altered mental status, one of these questions they're not going to be able to answer appropriately, right? So, it's just general confusion, not being able to answer these questions, giving incorrect answers, you know that they're going to fall in that moderate or severe category, right? Or if they have another injury, a head injury, right, we're probably going to err on the side of putting them in that category. But what exactly are we going to do for these patients? So there's a certain set of our treatments that we're going to practice later on tonight. All hypothermic patients get, regardless of if they're in the mild, the moderate, and the severe. Okay, so those treatments are these 4 things. So you got to remove all of their wet clothing, and I think this is, of all the hypothermic patients I've dealt with in the backcountry, I think this has been the biggest mistake that SAR teams usually make. You really have to get these people naked, into some warm clothes, or at least into dry clothes, before we do the rest of these treatments. Okay? And we can do that while preserving the patient's dignity, right, talk them through it, but it's something that needs to be done. Protect from further heat loss, we'll talk about what exactly that means. No alcohol, no caffeine, no nicotine, right? Alcohol is going to prevent us from shivering appropriately. Caffeine, right, is going to vasodilate. So we talked about vasoconstriction being a way that we shunt blood. Right? Caffeine is going to have that opposite effect, and nicotine is going to vasoconstrict to the point where we put ourselves at risk of frostbite. Okay? And then always, don't forget to assess for other injuries, right? Just because they're hypothermic and we're going to start treating hypothermia, do not forget to take care of the broken leg. Okay? So what do we mean by protect from further heat loss? I'm recommending this is a very discrete skill, and that is the hypothermic. Many of us in the room are already accustomed to doing, but just for those of us who need to review, right, that base, the outside layer is going to be either a tarp, which we're accustomed to using in SMR. It could be a mylar blanket. We have a number of those back here in green and silver. That's going to be the base layer. Even a rain poncho if we don't have anything else. Next layer will be some sort of foam pad or insulation, then a couple sleeping bags. So at least one under, at least one on top of the subject, and then we're going to roll that all together. So that's kind of the base way that we protect from further heat loss, regardless of if it's mild, moderate, or severe. Okay, so what are the additional things that we're going to do for that mild category, right? So This person, right, because they have a normal mentation, right? They're conscious, they have no problem conversating, right? No problem answering those questions. So they're going to be able to protect their airway and they can eat and drink. And we talked about metabolism being the most important way that we can generate heat. So they need to start doing that. So what do you think? If you only have cold water in your Nalgene and a candy bar, is it okay to have them drink that cold water even though they're mildly hypothermic? What do you think? If you don't have a stove with you, you don't have a way to heat up the water.
Then yes.
Any sort of water, if it's warm and it's sweet, all the better. Encourage light exercise, and I would recommend that give them a couple minutes. The sources say 30 minutes. Make sure they're out of their wet clothes, into dry ones, they've eaten and they've drank something, and they've been stable for half an hour, then have them do light exercise. I think that's up to your judgment. You know, just try to do these other things first, and when you feel they're ready, get them up and moving, like doing jumping jacks. Maybe if they're already in the hypo wrap, just then have them do isometric exercises, right? Just have them, you know, flex and relax their muscles. Mildly hypothermic patients are able to rewarm, right? And they should be able to self-extract. So for moderate and severe hypothermia, again, those same first 4 things, right? In addition to that, there's going to be this other set of treatments, right? So because they have this altered mentation, we're not going to be trying to force feed them water or have them eat, right? If they can't protect their airway, the kind of bar that I have set is like if they can't hold an open Nalgene and drink it themselves, then they have no business trying to put anything in their mouth, okay? And that's unfortunate, right? Because they're not able to use their metabolism, which is the most powerful tool they have to heat themselves up. So these people, the moderate and severe, are not going to be able to rewarm themselves in the field. Okay? So these are medical emergencies. Anna will talk more about this, why it's problematic to jostle or to not handle patients gently when they're severely hypothermic, but we want to keep that in mind as best we can, right? Of course, we're going to be jostling to a certain degree as we carry them down the trail, but keep that in mind when handling them. And then active rewarming to the core, right? So what does that actually mean? The charcoal vest, which empirically is the best way to warm up hypothermic patients based on the data that we reference. So why is that? So it's the best in terms of the heat to weight ratio because it relies on combustion, right? The chemical options, whether they be heat packs or battery powered, are just too heavy for us to actually bring them into backcountry and expect them to last for an 8-hour pack out in the middle of winter, right? Which is important for us because somebody has to carry it in the field. There is a low risk of carbon monoxide poisoning. There is a catalyst in this device, right, which should take care of that. But if you put in the battery wrong and run the fan in reverse, there is supposedly a small risk of that. Okay, so that's something to keep in mind. It's very clear on the device which way the battery goes in, but the fan does run in the opposite direction if you put the battery in wrong. Okay, so we don't have one yet, so I went and robbed the EMRU truck. Don't tell anybody, Nathan. So the way we have it set up there is all in a dry sack. And because Richard Duncan's in charge, all the stuff's always inside. So it comes with a AA battery, one of the charcoal packs, a lighter, right, so we can actually light the charcoal, and this is the device itself. Okay, so it's a pretty simple design. This is the exhaust tube that would go outside of the hypo wrap, and then this is where you insert both the D battery and the charcoal. So we'll go ahead and do that now. So the other component, right, are these tubes, and they just slide right in on the side into place, and then you'll put this on the patient's chest with the tube sticking outside of the hypo wrap, and then you'll wrap these tentacles around the patient. Okay, and so we're only wrapping them around the core, but it does a great job of distributing the heat all to this important area that we want to warm up. Okay, and we can, some lucky person can actually, it'll be providing heat regardless. So the key point, right, is the battery, how the battery goes in. So my recommendation, if we adopted this, would just to have like the directions laminated and attached to it, right, and just have somebody double check before we actually put it in with the hypothermic patient. I think that would be an easy double check before you, right, we double check safety stuff for rigging, right, this might be the same thing if we're actually really concerned about carbon monoxide poisoning, right, which would be a bad way to Yeah, that'd be unfortunate. Okay, so these come in sealed pack. Paper comes off. They actually give you 2 matches inside here, but we have a lighter as well. But the key thing is that the charcoal does not come out of this metal case, right? So the charcoal stays in here. There's a fuse at the top. So you just put it in with the fuse sticking out. Okay, you have the battery oriented correctly, and then you light this, and I'll go put it outside after it starts. But it takes about 5 to 10 minutes for it to... Oh, no way. Okay. So let that light. Okay. And once it starts going, just close it, put the tap on, and it'll start smoking.
Oh, is it on?
Okay, so we'll just let it snowball. So as long as we have all the components for the battery, we have the charcoal, and we have matches that actually light, then it's a pretty fail-safe option. Okay? It just takes 5 or 10 minutes to get started. How long is it run? So that's a good question. It runs, I think one charcoal pack runs for about 6 to 8 hours. Right, so it's a pretty long amount of time.
There might be an education piece too in terms of like using it in King County. I know that like the last time we used Sparks in King County, we ended up having this problem where as each group of new rescuers showed up, they tried sticking the hose back in because something was sticking out, you know?
Okay.
So like we have so many people from so many different units.
Orange duct tape tag. Orange tag is like rebound. See like a CO output or something.
Yeah, that
Sure.
would absolutely work.
Okay, yeah, so a couple things to make it even more fail-safe. So instructions on the device itself, right, saying double check the battery, and then some things. All right, so a couple things about frostbite, right? So this is another question, right? Difference between hypothermia and frostbite, right? For frostbite, you have to be in freezing or below freezing temperatures, right? So we have to actually freeze the tissue to cause the damage. It's actually ice crystals forming the tissues. Right, we're preventing blood and thus oxygen from flowing to the tissues and the cells, and they end up dying. So what are our treatments, right? So the treatments are very straightforward. Okay, so dry sterile gauze, it's in our first aid kits. We just make sure that the jewelry's off, watches, rings, what have you, and then pad between the digits with sterile gauze, and then you wrap the whole thing with sterile gauze. Okay? Very straightforward for us. This needs to be dealt with in the hospital, right? So we are never going to attempt to thaw frozen extremities in the field, right? Maybe if we were in Antarctica and it would be 3 weeks to get to a hospital, right? We would build an igloo and reform those digits because we can keep them warm. But for us, in our environment, we're just going to prevent further heat loss, do the rest of our hypothermia treatments, wrap them as such, and have them deal with it at the
A
hospital.
couple of things about this to keep in mind. So because you're wrapping feet and hands, you want to make sure that it's loose. You don't want to be cutting out circulation even more. And then also like a nice bulky dressing, so that you're not bumping the hand or the foot or whatever. The person probably can't feel this if it's really profound, right? And you can cause more tissue damage and injury if you aren't kind of aware, especially if you've got frostbite along with lots of other things. Just keeping it nice and padded, and also making sure that you're not accidentally wrapping too tight and there's no constricting clothing, cuffs, things like that could be sort of more severe problem.
Yeah, so it's a judgment call. So if somebody is maybe just mildly hypothermic, maybe not even hypothermic, but someone that has frostbite, right? They're going to be able to ambulate. And so for that person, I would do these treatments and probably just have them make sure that their hands are in their jacket or in some other fashion to get them close to their core as they're walking out. If the patient is otherwise hypothermic, we're going to be taking care of that, preventing further heat loss with just having them in the hypo wrap. Okay? So then I just want to have a couple quick photos of Bothy. These are used for alpine climbing, hiking, and mountain rescue in the British Isles. And it's something they use on every mission, pretty much. And so the idea is, it's just this tarp. Bree brought one tonight. They come in all different sizes, between 2 to 6 to 8 to 14 person sizes. And the way they use them in search and rescue and mountain rescue in these areas is every time they come upon a patient, they have a hasty team of 4 to 5 people. Everybody goes under this tarp with the patient. they pull the tarp down around the backside and they sit or kneel on it, so they create just like an environment that's like relatively warm and out of the wind and out of the snow and rain. And then they do all the treatments of the patient inside. Somebody else might be outside preparing the litter and whatnot, and then when it's time, they'll move the patient to litter. But all the treatment's done in this warm environment. So we've talked a little bit about how applicable is it going to be in like our environment, and it might not be always applicable, but there would be some situations potentially where we could do this. Like Bree and I talked a little bit about maybe a flat spot on a trail on Mountainside, Tiger Mountain, or wherever we happen to be, where we want to get the patient out of an inclement environment while we treat them before we package them out. So it's something that we'll mess around with tonight, and it's up in the air whether we end up actually bringing it to the field. But the smaller versions are great for personal times. Okay, so that's all I had if there's no additional questions. And now Anna's going to talk to us a little bit about the ALS side of things. And then we're going to spend the rest of the time actually getting hands-on with you.
Okay, so just a little bit longer here with some of the lecture type stuff. I just wanted to mention a couple of things for us to be thinking about that will help us out when they get to the hospital. I work in our review. I see a lot of these folks that come in, and I'll tell you that even trauma patients that are brought in by our local Seattle fire medics often come in cold. It's better to get them to the hospital rather than worry about this stuff, but this is going to be a good thing sort of for us going forward. So number one, so in trauma, have people heard of the triad of death in trauma? So it's illustrated up here. Basically, when somebody sustains major traumatic injuries, their body goes into this kind of hyperinflammatory state. They get and they're prone to these three things. So hypothermia, which we're talking about. Coagulopathy, basically their blood isn't going to form clots as well, and you can go into sort of paradoxical clotting versus bleeding. And then acidosis, that's when you have too much acid in your blood, and that's caused by lactic acidosis. It's caused by tissue hypoperfusion. And all of these three things, they basically, once you get into this kind of spiral, hypothermia makes your coagulopathy worse because the clotting factors don't work as well, the enzymes break down at a certain temperature. And then the coagulopathy will make your acidosis worse because you are clotting, bleeding, and sort of not really regulating in your intravascular space. So you're going to end up with sort of worsening blood flow to your tissues. You start producing more lactic acid. That in turn makes your hypothermia worse because your body is trying to sort of constrict down and hold everything into the core. Then you're getting colder and colder and colder. Any blood that's coming back is cold. So basically, in any kind of trauma patient, whether or not they started out hypothermic, it's something to, unless the temperature is pretty much, hot middle of the summer, I would say it's probably always a concern for the Northwest. And you want to try and prevent this from going into this kind of spiral because each of these things makes the other thing worse, if that makes sense. So, and this is something that we fight against really hard in the trauma bay when they come in because it's what will eventually kill them. Besides bleeding out or something like that, unless somebody is, has sort of an immediate threat to death from bleeding. So, something to always consider in any hypothermic, in any trauma patient, worry about hypothermia, even if it seems pretty minor, and certainly if it's major. So we touched on this really briefly. So the hypothermic patient in cardiac arrest, there is, and we'll go into this a little bit more. So does anybody know what we're talking about accidental hypothermia here. In patients who've had a cardiac arrest, we actually purposely cool them if they haven't woken up from it because we know that decreasing kind of your metabolic demand and actually makes things better for your outcomes. We are not making them really cold, but certainly colder than your average body temperature. So, does anybody know what the sort of lowest reported survival with neurologic sort of intact neurologic function from an accidental hypothermia is?
Time-wise, you mean?
Temperature-wise.
The temperature?
So it was 56 degrees Fahrenheit. So this woman who fell, she was a radiologist in Norway, and she fell into she was skiing, fell into a crevasse in like an underground river, and was probably had no vital, was basically dead for 40 minutes, and got extricated, taken to a hospital where for 9 hours they sort of slowly rewarmed her and supported her cardiac function, and basically she is now, has neuropathy in her feet, and is alive and well. So I know, I'll send you guys the article if you're interested.
It's a really good video too. and then making it.
It's incredible. So basically, the old sort of adage, you're not dead until you're warm and dead, is actually still being supported by guidelines in terms of wilderness medicine. So ways to think about that. So reasons not to start CPR. So you get to somebody who looks like they're dead. You feel for a pulse, you can't see one. They have no signs of life whatsoever. So, you have to think about, first of all, if they have obviously or traumatic injuries, if their head's on backwards, or they're, missing both legs and they have no blood volume left, you don't want to start CPR. If you actually physically can't compress their thorax, you don't want to start CPR. It's going to be futile. And if they're avalanche victims have been buried for a long time, and snow in their airway, high rate of this. Again, take this with a grain of salt. It's been shown sort of over and over again. These people have had almost minuscule chance of survival. I'm sure things have happened though, so I wouldn't even necessarily say that that's a complete contraindication, but that's what the guidelines say. So I'm basing this mostly on Wilderness Medical Society guidelines. So it's a little bit hard to read up there, but basically with severe or profound hypothermia patients, if you have the ability to support their respirations with a mask, you can ventilate them just with 6 breaths a minute or something like that. It really doesn't need to be very many. It says half standard rate. I would call standard rate 12 to 16. And that can just be sealed, mask. If you have advanced airway devices, great. And then CPR, no signs of life. So it sort of says you can use a cardiac monitor, blah blah blah. We're not going to worry about that, right? There's actually some evidence for intermittent chest compressions. If you need to get them out of the field, then using intermittent chest compression, do them for 5 minutes, you stop. How many people have done chest CPR on a live human being? It is really hard, even on somebody who's perfectly normothermic. So this is a big deal, right? We're carrying people out for a long time. Is this really worth it? It's actually because your metabolic demand is so low, and guess what? Some people can't survive without any kind of circulation, it appears, for long periods of time. You don't have to be doing CPR the whole time in order to sort of provide a standard of care even. And there's technically no temperature cutoff for CPR, which is interesting. So again, we're not going to know exactly how low people are when they're out in the field, but the suggestion is that there's no temperature cutoff, which is crazy.
Sorry. As far as like our protocol as EMTs in King County, they say withhold CPR regardless of rate. So what would be the advantage to doing intermittent CPR? Like, how would you know when to do intermittent CPR versus, we can't change our protocol anyway, but I'm curious, like.
So I think if you're in a situation where your rescue team is unable to continue the carry out or continue the extrication while providing continuous chest compressions, which you would be. So hopefully I would imagine these folks are going to be, are hopefully going to be flown out or something. You're not going to be carrying them out necessarily, but.
Well, we're just told never to start, so there's no instance where we would be doing CPR
so
on severely hypothermic.
Don't start regardless of rate. Explain to me what that means.
King County BLS guidelines say to check pulse for a minute.
Mm-hmm.
If you do not detect any pulse for a minute and there's no respiration, then don't do CPR.
Yeah. If that's our protocol, I think that's fine. But technically, if you have, all right. So basically, some of as you can sort of see, this is tailored towards ALS providers that have, maybe this is an urban, somebody showing up to a homeless person found down under his aqueduct or something like that. This is a little bit different, but these are written by the Wilderness Medical Society. So with that in mind, it's amazing. It was actually amazing to me that they still continue recommending CPR for folks like this. And then consider with rewarming. So we will be doing this for people. That there are some perils and some things to watch out for. So after drop, does that term sound familiar to people? So this is basically the people that are kind of in that moderate to severe, maybe on the line, and you start to warm them up, and at some point they stop squeezing down and completely shutting off the blood flow to extremities and things, and then the cold blood that's been sitting out there kind of comes back and gets to the core and then gets to the myocardium, the brain, sort of the other essential organs, and it can actually cause a decrease in temperature, sort of you can kind of come up and then come down again. It's pretty difficult really to avoid this because we want to warm people, but warming them gently and avoiding like having the person do physical effort if you're sort of, you know, if you're in a scenario where, you know, you're trying to get them out of a crevasse or out of the water or something like that, or like ways to avoid that. So just, you also have to just be knowledgeable of it. If you sort of get, if they seem like, you know, they were doing okay and then they kind of dip down again once you've gotten them a little bit warm, then consider that this could be happening, just monitoring it really closely. Hypovolemia, usually these people have low intravascular volume, they don't have, you know, you were able to give them more fluids through an IV than you would, but you can, once they start getting more medication, you're able to hold their nalgene well, you don't get fluid into them if able, especially more fluids. Is that again? No. Peri-rescue arrest is really interesting. This has been described, especially with people that are sort of rescued from cold water. They've been horizontal, maybe treading water or laying on something, and then when they in their hypothermic, the moment that they're able to climb into the boat, they sort of go from horizontal to upright, or they're climbing up a crevasse or something like that, and all the sort of fluid shifts. They don't have that nice horizontal position where all the fluid can sort of sit right here, and then it goes down to their legs, and they'll have cardiac arrest because they suddenly have this. It's like, you know, if you faint when you stand up too fast, almost like that. So keeping the patient horizontal and then preventing exertion when they're in that, like we talked about, in that moderate to severe, category. Arrhythmias. So this is a huge thing that we worry about in the hospital when somebody comes in and they're hypothermic. Basically, being cold makes your heart angry, and it's really sensitive, which is why a huge thing that we need to remember, I think one of the key points of this is to handle patients that are hypothermic with care, avoid jostling them, avoid dropping them, avoid kind of, you know, obviously if there's a scene safety issue, that would be really the only time that you're really, you know, trying to rush people out of a certain position or scenario. But really consider, you've got to move them carefully. It's not the patient that you kind of say, oh, you know, get them around the litter, we gotta run, you know, that sort of thing. This is going to be sort of the end game. You can actually, and I've seen this happen, from moving somebody over from the stretcher onto our hospital bed, cardiac arrest, and it turned out this guy was really cold. So handle with care, and then monitoring them frequently, and just, you know, if they're sort of kind of with it, but then not, and you're walking along, and then suddenly they're unresponsive, you know, check a pulse and make sure that they're not actually not having a pulse. And then a relaxed patient. So when people relax, they lose their sympathetic surge, they lose all those catecholamines that are like keeping them alive. So they actually recommend, so certainly, you know, no sedative drugs, don't give them pain medications. And if you have somebody who's conscious, keep them awake and engaged, and talk to them and say, hey, you're getting through this, you know, stay awake, stay with me, how you're doing, reassess them frequently, and that can actually help them sort of do their metabolism and get warm again. So, and I started the ones that I think you have to worry about the most, the after. Questions about that? Okay, so take home points from this part. So prevent hypothermia in common patients, they are super prone to it. Not tend to be morbid to a point if you're operating under an ALS protocol. I would follow the ALS protocols as long as we are operating in the field. But keep that back in mind. And then preventing complications of transport after dropping readiness. Handle with care. And be on the lookout for, you know, changes in status.